going to talk a little bit on early detection of fetal defect, which is the same, another way to say structural abnormalities in the first trimester. And then we will move to a live scan. I think that's the sequence. In the era where we all talk about cell-free DNA, it's important to remind us why it's so important to keep on scanning, to keep the first trimester ultrasound. We have, well, in the last 30 years, extensive studies from the group of Professor Nicolaides that showed us that it's important to turn the pyramid of care upside down and to focus on the first trimester, where you can actually better select and predict a lot of the main adverse conditions that will happen during the pregnancy. It is true that you can, in the first trimester, screen for major structural abnormalities, or for aneuploidies, for preeclampsia, for fetal growth restriction. You're going towards screening for premature birth already in the first trimester. And because we learn to see the baby in the first trimester, of course, we learn the anatomy, we learn how to look at the structures, and then we can detect more of the first trimester, of the major structural defects in the first trimester. Of course, for you to detect, you need to follow a system where you basically see the baby in the same way all the time. And what we do in the unit I work in Portugal, it's a copy of what I've learned at King's College. And we start in every patient. This happens in every patient. We start with an overview of the baby, and then we move to sections. We start, well, this is in the other way. We start from the head to the toes, and we start looking at the head and brain, and I'll show you that. I'm not going to take much time here. We see head, brain, and face, and then we move to the thorax, where you see the lungs, the skeletal part, and also the heart. Yes, and in the heart, we use, of course, the B mode and also the color, and also the SMI, which I'm going to try to show a little bit of the data we have. And then we go to the abdomen, abdominal wall, and the structures inside, and of course limbs. And that's what we do in absolutely all the patients. And we all know that if you follow that, you know this study, you have seen that many times. It's just important to remember that if we follow this structure, this structural examination, your defects will fall in 3 categories. Of course, there are abnormalities that you are not going to detect in the first trimester. There are abnormalities that you are going to detect in the first trimester, and there are abnormalities that are potentially detected. And we are going to discuss a little bit about the potentially detectable and the things that makes detectable and sometimes detectable abnormalities. So if you follow the criteria, you have these three groups of structural abnormalities. These are the examples of abnormalities that you are not going to see in the first trimester. Well, you're not going to see, for example, abnormalities of the corpus callosum. That's simple, because the corpus callosum is not there in the first trimester. So if the organ that you are looking for, it's not there, you cannot actually detect an abnormality. There are studies that show some markers that you can use maybe to suspect, but you cannot really detect the structural abnormality in the corpus callosum. The same goes, the same goes for the cerebellum abnormalities. You don't have one yet to detect the abnormality. And for abnormalities that, even though the abnormality is there, whatever makes you see the abnormality is not visible yet. For example, the cystic adenomatoid malformation, although the lung problem is there, the accumulation of fluid that makes the lung look hyperechogenic, or the cyst that forms, are not there yet. So the abnormality is there, but whatever makes you look at the abnormality, it's not there yet. And of course, there are abnormalities that you acquire during the pregnancy, like, for example, bowel obstruction. There's something that you don't have in the first trimester, then you have later on, and of course you then, and the same goes, for example, for cytomegalovirus infection and this kind of thing. So there are abnormalities that you are not going to detect. These are the abnormalities that we always see in the first trimester. And if you look at them, you will realize that you see them all the time because they are easily recognizable. We know already how to assess this kind of image. So we all do a sagittal view of the baby when you are measuring CRL. And you cannot actually miss anacrania, because when you are measuring the CRL, you actually see that on top of the head, it's a little bit odd. The same goes for holoprosencephaly, a lobar type of holoprosencephaly, where when you are looking at the brain in a cross-sectional view, where you should see that butterfly shape of the choroid plexus, you don't actually see any of this. Exomphalus and gastroschisis you can also see in the same section. When you're looking in a cross-sectional view of the baby to see the abdomen, or when you're looking in a sagittal view, and you can actually see there is something coming out through the abdominal wall. And of course, megacystis, I don't show you here, but I have image afterwards, and body stalk anomaly. They are completely different structure from the normal, and you can always detect. So there are abnormalities that we are going always to detect. I'm just going very fast through these slides, just to show you have three kinds of holoprosencephaly. The ones that you may detect in the first trimester, you always detect the lobar type. You may detect the semi-lobar type, but you are never going to see an lobar type of holoprosencephaly. If you are lucky, you see that in the second or in the third trimester. This just to show you the prevalence is around 1 in 1,312 weeks, much less at birth. There is a high relation with trisomy 13 and 18, and a little bit of a relation with genetic syndrome. And if it is an isolated abnormality, there is a 6% chance of recurrence. The same for exomphalus. The bigger the baby, less often is for you to see. If there is liver, the prevalence is about 1 in 3,500. Just to remind you of the strong association with chromosomal abnormalities, trisomy 13 and 19, and in 10% of the cases, some genetic syndrome, the mainly Beckwith-Wiedemann. And if it is isolated also, there is no increased chance of recurrence. If it is together with a genetic syndrome or with a chromosomal abnormality, the recurrence is the same as genetic syndrome or the chromosomal abnormality. The megacyst is, what defines megacyst is a bladder diameter higher than 7 millimeters. There is a strong association with aneuploidies. The prevalence is around 1 in 1,600. And interesting, if you have a bladder that is less than 15 millimeters, these are the bladders that the megacysts that are more likely to be related with chromosomal abnormalities. And the chance, if that is not a chromosomal abnormality, the chance of resolving spontaneously is about 90%. If it is too big, more than 15 millimeters, it's likely to be reversible, and it is also likely not to be related with a chromosomal abnormality. Just to remind a little bit of that. Then we move to the fun part of the structural abnormalities, the ones that are potentially detectable. It was called sometimes detectable, but I prefer to call potentially detectable. Why they are potentially detectable? I'll show you some examples. They will depend on you learn how to see, how to detect the abnormality, how to see the structure and how to detect the abnormality. They will depend on you having technology that may help you to see better a structure so you can detect more. And they will depend on markers that you have that will help you to think or of the presence of these abnormalities. And I just show here the example of what happened when you have an open spina bifida. You all know the brain is pushed down, back and down, and therefore the brainstem compressed the posterior fossa. So by measuring either the fourth ventricle, called the intranuchal translucency, or making a relation between the posterior fossa and the brainstem, you can actually think you can think of an open spina bifida. Another very, this is just to show you how the impact on the learn how to see. And this is not published data. This is just a comparison from what we have seen in the unit I work and what is published. In the original paper from 2011, they detected about 5% of the facial cleft, of the cleft palate. And in my unit, when I went to look for the last years, the cleft palate that we had, we detect all of them. But what was the difference? It's not because, it doesn't mean that my unit is better than the unit the publication was made. It just showed that when this data was collected, was not part of the structural assessment of the baby to see the palate and to look at the retronasal facial triangle, where you can actually see the anterior process of the maxilla, the nasal bone up here, and the palate there as the base of the triangle. And if it is closed, you probably don't have a cleft palate, and if it's open, you're probably having a cleft palate. So in the original study, it was not part of the assessment. In the unit I work, this is part of the assessment in every single patient. In all patients, we look at the face, and we look at the face, we see eyes, we see palate, and because we look at that in every single one, we detect all of them. Well, so far, yes. Of course, there is a big difference in the number here, but it already shows, even when we reach 20, if we don't detect any other one, the detection is greater. So if you learn how to see a structure, you will likely to detect more of the structural abnormality. It is also true that for megacystis, we didn't have the same detection rate as in the study. For the study, they detect all of the megacystis they had. And in the unit I work, we missed one. What was the difference? So our detection rate was 87%, while in the study was 100%. What was the difference here? The difference is that in my unit, before we missed that, the assessment of the bladder was actually a subjective assessment. So you look at the bladder, and if the bladder looks fine, the size, so the bladder was fine. And in the original study, the bladder was measured. The longest diameter of the bladder was measured all the time. So they detect the difference between 6 to 7 millimeters. It's easy to detect if you measure them, but by just eyeballing something, yes? And that's why the one we missed is actually this one. We pick it up later on, but we missed this one in the first trimester. So the person who looked at the baby, yes? Transabdominal. We do that, I mean, 98, I will show you the data a little bit more. 98% of the time we do transabdominally. Okay. And then by measuring that, you can actually detect better. So that's what happened. We eyeballing that. Someone who've done that thought that was a normal size bladder and didn't measure, so we missed this one. So that's important, learn how to see the abnormality. A good example of markers that can help you to assess or to think of a structural abnormalities is what you have for cardiac abnormalities. Professor Nicolaides put together a very nice screening test for major cardiac abnormalities, whereby looking at the markers that we are used to, nuchal translucency, ductus venosus A-wave in this case, and tricuspid regurgitation, you can, if you move to the last 3 lines here, you see that you can detect up to 58% of the major cardiac abnormalities to an 8% false positive rate, which means that you detect more than half of the cardiac abnormalities, and your cardiologist will see 8% of your population. You may tell me, well, that's not really a big and a fantastic detection rate, but what we do nowadays is just to send to the cardiologist people that have a sort of history of increased risk for cardiac abnormalities. Medication that increase risk, siblings with another cardiac abnormality, mother with cardiac abnormalities. And this system of screening detects only 10%. So by adding tricuspid regurgitation, ductus venosus, and nuchal translucency, you increase in nearly 6 times your detection rate by doing something that you're already doing and using that to detect a structural abnormality in the heart. If you have a lazy cardiologist that doesn't want to work very much, you can reduce the false positive rate, so the number of patients that you're going to send to him to 4% and not losing much of the detection rate. Your detection rate decreases to 53% if you just add your cutoff for the NT to the 99th centile instead of the 95th centile. And if you do tricuspid, it's actually you know how to assess a 4-chamber view of the heart. And if you know to say, I mean, if you say, oh, this is proportionate the 2 sides of the heart, the size is okay, the heart is to the left, then you increase even more your detection rate by using a normal four-chamber view of the heart as a marker to 75% of the major cardiac abnormalities. So here you have a good example of how markers can help you to detect more structural abnormalities. Learn how to see. Again, I mean, there is room. We know that there is room for people that want to look at the heart, that you can detect more. And a study published this year in the White Journal showed that it's actually feasible, and people can learn how to easily assess the heart by looking at the four chambers and the three-vessel trachea view. And this is feasible in about 93% of the times to properly assess the four-chamber view, and it's feasible in about 87% of the time to properly assess the three-vessel view. And this can be used to look at the heart. But I want to show you just an update version of the study we are about to finish on the using of a new technology that can help you to assess better the heart. It is called the Superb Microvascular Imaging, SMI for the friends. And this is what we have so far. We have a two-step study where in the first step, this is what I'm going to show you, we scan 1,913 patients, normal patients, in an unselected population. We had in this group 17 cardiac defects so far. And it's just to show you that it's actually an unselected population. BMI in my area is about 25%. Some of them are from IVF pregnancy. The average maternal age is 30 years. The history of cardiac defects in the family is about 0.4%. The mean NT is normal. Tricuspid regurgitation incidence is about 1.8%, a little bit lower than what I was expecting. Ductus venosus PI mean is 1. The average risk of the mean risk for trisomy 21 is 1 in 6,000, and 98.8%, to be more accurate, of this patient was assessed via transabdominal. So the image I'm going to show you is they are all transabdominal. And what we do is just compare what we do nowadays, B mode plus color, high definition color, versus B mode plus color plus SMI, to see how much SMI can help you to see the heart. This is the kind of image that you have when you're using SMI. We'll try to show you a little bit. These are all patients between 11 to 13 weeks. And when we are assessing the visualization of the structures of the heart, as we do in the second trimester, we see that for the fourth chamber, actually, we don't really increase much of the visualization of the heart. That's because we are used to look at the fourth chamber in the first trimester all the time. But if we consider the proper visualization of the interventricular septum here, it does increase your visualization. But for the general visualization of the fourth chamber, it doesn't really change very much. The magic comes when you go to the outflow tracts. So looking at the left outflow tracts, the aorta, sometimes it's tricky in the first trimester. To have a clear view of the connected aorta to the left ventricle, it's even more difficult. Without the SMI, you do that in 70% of the time. With SMI, it increases to about 95% of the time. If you go to the pulmonary artery, it's the same. If you consider that for you, in the second trimester, you're only happy to say that the pulmonary artery is the pulmonary artery if you see the branching of it. So why not doing the same in the first trimester? If you consider that by looking the pulmonary artery, you need to see the branching of the pulmonary artery as you see there and as you see in the video there, you only see that properly in 65% by using B mode and color, high definition color Doppler. If you're using SMI, you see that in 91% of the time. Same goes for the three-vessel view. We found that if we don't use SMI, you see that in 88% of the time, similar to the study I showed you before from France, you see that in 88% of the time. But if you use SMI, you see that in 98% of the time. Why that? Because you actually see the SMI better defines the Doppler area. And because it works in a subtraction mode, it removes everything that is sort of a contamination movement and everything. So defines the Doppler area better, so you can see pulmonary artery, you can see aorta, and you can actually see the superior vena cava, where by using any high definition Doppler that you may think of, you have an overflow of the pulmonary artery, of the aorta, and a little bit of overflow from the superior vena cava, and this looks like one. So you cannot see that. You cannot say that you're looking at the three-vessel view because you're looking at two. But if you're considering the three-vessel, SMI helps you to see much better. And that's the most interesting part. When you're not using SMI, you can see all these aspects in about 81% of the patient. But if you use SMI, you increase the visualization of this of the structural abnormalities to of the structural heart to about 95 or 96% of the time. So it really helps you to see the heart all the time. This is by seeing all the structure in the same patient. Yes, you can only see all these structures in the same patient in about 81%, by not where you're not using SMI, but in 96% of the patients when you are using SMI. And better than that, even in situations that are more difficult. Yes, this is tricky. We measure the distance from probe to the fetus, and then we consider if you look all the structures that we should look in the heart, and that's the average distance from probe to the patient that you can see all the structures without SMI. And the average distance is 70 millimeters, 7 centimeters. If you're using SMI, your distance increases to 86%. So it not only helps you to see better, but also helps you to see further or more distant, yes, in situations that are more difficult. Of course, well, it's not as strong, the difference, as in the other things, but actually there is a very good trend on that. So it helps you to see better. Well, just to finish, structural abnormalities in the first trimester, the detection of it will depend on some things. It will depend on the time you have to scan. If you have 5 minutes to do a first trimester ultrasound scan, you shouldn't have high hopes of detecting a lot of abnormalities. It also depends on the objectives you have for the scan. For example, if it is not part of your routine examination to look at the hand, you're never going to see a syndactyly in the first trimester. It, of course, depends on your expertise. If you start scanning yesterday, your detection rate for sure will be different from someone that is scanning for the last 20 years. It also depends on the equipment. Of course, you cannot do nowadays a proper examination if you're using a 50-year-old ultrasound machine that you actually need to rotate something just to switch on, and then you need to wait, and you need to light a candle, this kind of thing. This is rusty. You cannot use an old equipment. You need to have some sort of a new one that have a better definition of image. And will depend on, and in this, you enter the help of new technologies that help you. And of course, will depend on you knowing how to see the structure you want to see, and also markers that can help you to assess better the structural abnormality. I thank you all very much for your time. I will try to show you a little bit of what we do. Okay, baby is not, no, it's a little sitting, but not that much. So we always start, and I'm not going to say that Petra didn't load my presets. You have two sets of presets. You have my presets, and then the presets that Petra calls as mine. That's okay. So when we're starting a scan, we just, as I told you, we have an overview of the baby to see if the whole baby is there, and then you look at uterus there, see the placenta flow, the placenta cord insertion, look if there is only one baby, 2 or 3 or 4, and if the baby is inside the uterus. That's a good start. And then we move to the baby, and as I told you, we sort of always start from the top of the head, and in a very slow sort of movement, we just scroll to the bottom. You see the skull, you see the brain inside. We're going to the eyes, and then we move it to the palate. Well, try to show you here if the baby remains in the same position or not. That's live scan. That's why it's called live scan. Yeah, so we move that, and we come back there later if the baby truly helps. Yeah. Then we go there to the thorax. You see lungs. You see the heart. We're going, well, we can move to the heart now. The heart is the only thing that makes me change everything. Because if the heart is in the good position, you cannot actually lose the chance of looking at the heart. And then we see there everything that we should see. 4 chambers, not really in the good position, in a good cross-section for you. But you have here 4 chambers, nicely, 2 valves. Yeah? And then the baby decided to point with the hand there. Then aorta, pulmonary artery, and the trimester. So I will try to show you with the SMI. We move to this one, yes?
Is it a different probe?
Yeah, just changed. Well, the SMI works in every probe. Am I lying? No.
No, you're not lying.
I'm not lying. SMI works in every probe. I just like the presets of this probe more. And also, because, is that something I can say?
I don't know yet, but you haven't said so just
No,
say.
and there is a new SMI. So the image I show you was from the old SMI. I define things as new and old. They have new names for that. And
This is new.
this is the new. I think the definition is better, even better from what we have. You see the baby decided to go around. So you see the interventricular septum very well. Bye-bye, baby. Come back. Let me just have this. She's completely decided to let me down now.
People
Okay.
are so friendly, they're just laughing at you.
Baby, where are you now? What are you doing? It was very nice before. It was behaving very nicely. This has actually no real preset. Yes, so that's more or less a raw image. We can improve it a little bit more. But just to show you, do you have? Yeah. You can see the four chamber view very nicely. Yeah. You can see the interventricular septum very nicely. Yes. You can also see something that we have in the next phase of the study. You can see the pulmonary veins, which is very hard to see usually in the first trimester. And then you move on to the outflow tracts, and you see aorta right there. Yes? Just because I want to show, the baby decided it was not worth to show. Yeah, you can see that. That's the beginning of the aorta, and you have a clear and intact connection to the left ventricle. That's very nice for heart assessment. And then now the baby just went completely mad. That's good. I wanted to show you that. Look at this image of the fourth chamber there. You see that in the 2D you don't really see very much. There's something wrong with the SMI that actually works in our favor. As a normal Doppler, it depends a little bit on your insonation angle. SMI, I don't know why, they can explain you later. SMI doesn't have this kind of condition that the normal Doppler has. Less. It has less, yes. So it doesn't, for example, if you are in this view, yes, in a transverse view, and you want to see the Doppler here, the Doppler doesn't show very nicely, but the SMI does. So it doesn't behave exactly, although it's the same Doppler signal, the algorithm reads it differently, so you can actually see better. Just going to carry on, and then we come back to the heart later. Or should I just keep looking at the heart? So we move from the thorax to the abdomen. I'm just going to press a little bit. It doesn't harm the baby, don't worry. Okay. Yeah. Huh? Yeah. Then we have, so abdomen, stomach, you all know. Umbilical cord insertion, I'm going to point out there. Then we use high definition Doppler to try to see the number of vessels you have in the umbilical cord. Then we move to the limbs, and then you assess the limbs in the transverse view, and also trying to see a longitudinal view, feet, and hand. Now the baby really decided not to behave. Hello, baby, move around. Spine. Well, every time I speak of something, the baby just decides not to show. The back, you see spine, you see kidneys there. The one kidney there, the other kidney is there. You can, if you like colors, you can just try to show there with the high definition Doppler there. But sometimes SMI also works here, but yeah. Could I? Yeah. You have this also, this is also SMI. This is called, whatever it's called, color chrome SMI.
Color SMI.
I don't like this very much. I prefer the other one.
This one?
Yeah, I prefer this one better. Okay, that's my. But yeah, that's simple. I mean, if you want to show together the structure is nice. The thing I like in the SMI is actually the subtraction mode. For the heart, this is the old SMI. Is that right? Yeah, this is the old SMI. You see the difference in the quality of images. The new one is really nice. You can see there the diaphragm. You can see the lungs, bowel, liver. Nobody cares about liver. Then you see here everything. And it's a nice baby. Doesn't behave well, but it's a nice baby. Doesn't like Brazilian guys. It was behaving nicely like 5 minutes ago. Yeah, it's terrible, this baby. It's like misbehaving all the time. Yeah, I wanted to show you that. So now it's really nothing there. Let me try to go back to the heart. Do you have like more 2 minutes?
How many minutes do we still have? We have 2 minutes. Oh, wait. Heart?
Heart. Just want to show you if I can actually. Maybe I cannot. Yeah, maybe now. But try to show you the pulmonary artery, but not really in a good setting for that, position for that. Yeah, we have the pulmonary artery there, but I cannot really show you the. You see the pulmonary artery, you see the aorta, a little bit of superior vena cava. I was glad if the baby could turn around a little bit, but yeah. Do you have any questions?
Yeah. Any questions? While the Dr. Cruz is still with the transducer on the baby, something you want to see specifically? No? Ah, there's was. Okay.
Sorry? I didn't understand.
You're doing a brilliant job, but would you be able to show us ductus venosus and tricuspid regurg, please?
Sorry, I did.
Ductus venosus and tricuspid regurgitation.
Okay. I hope I cannot show you tricuspid regurgitation. But the ductus venosus, yes. There you have. Yes, ductus venosus. You have the aliasing there, and of course the baby is moving. And now I pressed the wrong button. Yep, you can do ductus venosus in either position, with the baby facing up or the baby facing down. You should have a proper sort of sagittal view of the baby, good magnification, and then place the color. I'm using here the ADF, high definition color. You can use SMI, color SMI, or if you like, you can use this nice color, this nice SMI. You see. It looks like you like it, isn't it? But I like to measure. Of course, you can see that with the SMI. You can see where to place the caliper. You see the ductus venosus there. You don't really need to rely on the on the aliasing. So then you just measure that. Okay. Then you should. How do you increase the sweep speed?
Oh, the sweep speed.
Yeah, you should have a higher sweep speed to see better the A wave, and then you measure. Nowadays for trisomies, you measure that. Tricuspid, I hope I can show you. the heart there. Yeah, you can also do as you do with the ductus venosus, either from the front, from apical view, or from the back. You need the baby to be still to measure that, not the case. Of course.
Why measuring ductus venosus PI at 12 weeks? I mean, isn't just the waveform the most important thing at 12 weeks?
No. For heart assessment, the A wave is important. For trisomy 21 or chromosomal abnormalities, what we use nowadays is the PI. Yeah, the higher the chance. By using the PI, you increase a lot your detection rate. The PI of the ductus venosus on its own, as a marker, as a screening test, has a 60% detection rate. So it's really, really important, the PI. And that's the tricuspid there. You should have, you don't need to use the collar, you just need to place in the right place. And what you try to do is to have, just want to show you something. You just try to sample across the valve. You start close to the septum, and then you move along the valve just to trying to get all the valve, to assess all the valve. Okay, now I'm just going to move on to ADF because the baby now is behaving. So you see that's very clear. Yeah, you see the aorta. You can see that, yes? Then you see pulmonary artery with the branching. And actually you see something very nice because you see all the branchings of the pulmonary artery when you have a nice view. That's not really clear here, but you can see the left and the right branching and the duct. So it's really nice there. And that's what I'm talking about. You can see the 3 vessels in the 3 vessel view. Any other question? So thank you all very much.
Okay.
Thank you.